using your 4-month active TB treatment regimen, what drug is used besides our zonafib, ribofentin, and your pyrazonamide? All right. So when we're looking at these, what I want you to do is make sure that you go through and you're getting all of your meds together with your 6-month versus the 6 to 9 month, okay? So that's the big thing whenever you're studying for this is active 4, 6 to 9 month, and then looking at latent and what you're doing to treat for your latent, okay? And then go through and just write off those little adverse effects that we were talking about going to that drug. When do I prefer to use this over the other one kind of thing? That's the easiest way to go through this lecture. What are the clinical uses for rifampin? All of these, right? Some of them more so than others, but all. We won't see rifampin as something that we would typically pull out from MRSA. We have our other drugs that we talked about. So like, these are just any type of indication that you can see for rifampin. Besides lowering the pH of the environment inside the bacterial cell wall, pyrazonamide also does which of the following? So mechanism of action question. Fatty acid, right? Okay, so inhibiting the fatty acid synthesis of the cell, right? And which of the following can influence the activity of our sinuses? Read the question. So when we're looking at this, right, this is talking about like interacting with. So B6 could, if I was a drinker, that could also interact with it, okay? My food, so like looking at these, you can kind of go through all of this. What do I give B6 for with isoniazid? What do I give it for? To reduce what? What? The neuropathy? What is that what you said? Yeah, different drug. Yes, the neuropathy that they were experiencing. So remember, when you look at isoniazid, we had the foot. And we had all those tacks like going into their foot for the neuropathy that they were feeling. So that's why we give them the B6 with the isoniazid to help decrease them feeling that way. Okay. So I will look on there. I think there are some questions that are on there, practice questions, but essentially they'll look like this. I'm telling you what I want you to look at and what to study. Separated 4 months treatment, 6 to 9 month treatment for your active, and then go over to your latent. What are my options that I have that are preferred? And then looking at your adverse effects of those drugs, like the big ones that kind of stood out that were weird. Do I need to worry about eating with this? Yes, no, those kind of things, okay? This is all right. Your antiviral. Is everybody downloaded? We have it already. Let's go. Okay. So when we're looking at our antiviral medications, there's several different viruses. Can I treat a virus with an antibiotic? No, I need an antiviral medication to treat a virus. So we're going to go through some of the common things that you guys are going to see when we're talking about our viruses and how we're going to effectively treat our virus. Understand sometimes and most of the time when we're talking about a virus, it's very hard for us to get control of it, especially if that patient hasn't come in sooner to you, because then the viral load starts to increase quite a bit. And so our drug is having to work a little bit harder to get that viral load under control. So when we're looking at these, just make sure that you're keeping in mind, most of the time people will be on these medications for the rest of their life or whenever they have a flare of some of these things that we're going to talk about. So your ELOs are going to be listed here, the same things that we typically are talking about, mechanism of action, my indications as to why I'm using them. The bigger side effects are going to be another thing that we're looking at in these meds. So just a little bit of background and when we're talking about a virus. The virus is going to depend on the host. So they're a parasite, right? Because without my host, I'm not going to be effective. So they kind of become one with that host and say, all right, I'm going to hijack whatever I need from this host to make sure that I can continue to replicate, make sure that I can continue to survive. So big thing there that I want you to remember is that they are essentially hijacking that host material to make what they need and to replicate as a virus. So looking at influenza or the flu, what do we know about the flu? It's a virus.
Lots of them, changes all the time.
Changes all the time. We have to get vaccinated for it every year, which also, because it changes all the time, our vaccines typically change every year. They have different strands that they put in it. As a healthcare provider, this is a big thing for us. I used to hate getting the flu shot until I went into the hospital and worked in inpatient and saw how many people come in with complications because they have some type of underlying health condition and then they get the flu. Okay, so it is something that people still get sick. We had COVID, and then we forgot about the flu, but the flu is still also a big deal. Okay. So when you're looking at this, this is kind of what we were talking about. We have 3 different types of the flu virus. You have A, B, and you have C. When we look at our influenza A, you're going to have different types of vaccines that we will pull out those strands and we will say, hey, most of the influenza that's occurring this year is going to be from these strands. So that's what we try to cover when we're doing our vaccines. We may not have every single strand that we know that is infecting people that year, but we're going to have the most popular ones that are going to be compounded in that medication. Okay, so out of the 3 types, we typically use type A and type B when we make our influenza, our flu shot. Okay. So this is a good summary slide for you to see kind of where your medications are going to work and kind of what happens. So you'll have that virus that it gets into your host cell by endocytosis, it's engulfed, and then that viral RNA starts to continue to be incorporated and replicated using all of your host machinery. Okay? So this is again just saying, hey, once that virus gets inside, these are different types of ways that they can continue to become infective. So you have uncoating that can happen, they have replication that can happen. So you see different medications are saying, I don't want them to uncode, therefore, or uncoat, and therefore it will be hard for us to replicate them. You have different ones that will go in and try to stop the replication. And we'll go through all of these mechanisms whenever we look at the actual drugs. So this is again just a little snippet of what you're going to look at. When we talk about budding, this is going to be whenever that virus has done, it has replicated and now it's trying to get back out into the bloodstream, into that patient's body to continue to further infect other cells, right, to spread. So we have medications to where they won't bud off. They won't be able to cleave off and go and continue to spread throughout the body, okay? So when we're looking at this, just understand that we have several different drugs that are going to target several different pathways of that virus actually being replicated. We want to stop the replication. Again, when we're looking at this changes all the time, so I don't want you guys to memorize this. You're going to get this from somewhere else. Just understand that when we talk about flu season, we typically want to start giving flu shots around October-ish time frame because we have our peak November, April time frame. Now, when we talk about this, that does not mean that that window where we have a lot of people getting infected, that doesn't mean that you can't get infected outside of that window, okay? Because I think my daughter one summer had the flu and I was like, it's not even flu season, and she had her flu shot. Doesn't mean anything that you have your flu shot, it just makes it more tolerable sometimes for people when we have our vaccines, that if they do get whatever that is that we try to vaccinate them against, that it's not as bad. But again, we have this time frame, does not mean that you can't have the flu outside of that window, okay? This is now looking at my contraindications. When can someone not have or get vaccinated for the flu? When we talk about any type of contraindication, and it's not listed on every single slide for every single drug, but if you know that somebody has an allergy to some component of that vaccine, of that medication, we won't give it to them. So that's all this is saying is if they have some type of allergy to the flu vaccine that is documented, and for the military, for someone to be exempt from getting that flu vaccine, you have to make sure that that patient knows to come back in and they talk to you so that it is documented. And most of the time, they're going to want to see whatever that reaction was. You can't just go in and be like, yes, well, last time I had anaphylaxis. You're gonna be like, where is that documented? Did you go into the ER? Because we're gonna have to pull those records to exempt you from getting the flu shot. When you're looking at your live attenuated influenza vaccine, this is essentially like, there's two different types of flu vaccine. We have an inactive, which is typically what we get in the shot, and then you have the live, which is one that you can do through your nose. So when we have the live, there are several different reasons as to why you would not want to give that live vaccine to your patient. So if they are pregnant, we are going to try to avoid it in our pregnant patients. Also, if somebody is immunocompromised, we want to watch out for them also. When you're looking at the other ones, those are definitely contraindications. The other big one that I want you to know that pertains to us is the healthcare workers. If you are in a floor or if you are in an area where you are going to be dealing with immunocompromised patients, we don't want them to ever come in contact with that live vaccine. So you as a healthcare provider should not be getting that live vaccine either, because then when you have contact with your patient, there's a potential that they can then be exposed to it as well. So that's why you see this healthcare workers, or if somebody lives in the house with somebody who's immunocompromised, they should be avoiding that live vaccine as well. Now, when you see precaution, this is again like that, doesn't mean that they can't have it. We're just watching out for them, monitoring them, making sure that they understand what to look out for. So when we look at somebody who's already sick, can they get the flu shot? Yes. A lot of providers will give the flu shot still with someone having, just a regular cold illness. We typically give the flu shot. Because when they come and you tell them, oh, you're sick right now, come when you feel better, they're probably not likely to come back. So most of the time we usually vaccinate them. And then your patients who have Guillain-Barré syndrome or GBS, if they are going to have, if they had that activated within 6 weeks of them previously having a vaccine, then we want to make sure that we're watching out for those patients, because that means that can happen to them again. So again, a precaution does not mean that those are an absolute contraindication on the bottom. Look at your contraindications that are on the top, okay? And when you can and cannot give those. This is just giving you the composition of what our vaccine is looking like for the 2025-2026 year. So nothing that I need you to remember, just remember that you have 2A, 1B. Okay, it's a trivalent vaccine, so 2A, 1B. What happens, DOD gets together, FDA, CDC, they all get together and they're like, all right, let's do some research, let's figure out what are the strands that we want to treat, and this is how they kind of rotate what's happening every single year. So you'll look at these and you'll see that this varies every year most of the time. But we are in a trivalent where we have 3 right now, so 2A, 1B. Your dosing schedule and what this looks like. If you end up with a peds population, this is kind of where this becomes more of a thing for you. So, let me get my mouse. Okay. So here you have somebody who is 9 years or older, and this is the first time that they're getting the flu vaccine, which is kind of unrare, but now it's becoming more rare as people are starting to not vaccinate, okay? So you can start to potentially see more of this happening. So 9 years old, they present and they have never gotten a flu vaccine. Then they'll get their first vaccine, and then they're going to need another vaccine within the next 4 weeks. Okay, so you're going to have to treat them again. When you see that, if I am younger than 9 years old, so younger than 9 years old, then what you're going to do is you're going to give them that vaccine, and then within 4 weeks they need to get another dose. I was the person who did not bring my kid back. So I was like, oh, she got 1, she'll be fine. So essentially think of this as their first time getting it is a loading dose, right, for your kids who are under the age of 9. So they have this loading dose, but they have to have it within 4 weeks of each other, okay? So I'm 2 years old, and I bring my kid in, right? And I'm like, here's my 2-year-old kid. You give me the vaccine. I have to come back within 4 weeks to get another flu shot, same exact flu shot, but within 4 weeks. If not, they start it over again. And they will continue to do that every year if you don't have those two within that first 4 weeks of each other, okay? And then I think I said something that if they're over 9, then they just need that, they'll get 1, just 1. So under 9, 2 within 4 weeks, over 9, just 1. Okay, and then they do that every flu season. Looking at my adverse effects, they're not horrible. A lot of people will tell you like, oh, I got sick when I took the flu vaccine. A lot of the times that's just like that injection reaction from it happening, but for the most part, most people are okay. Just looking here, you see that because I have punctured your skin and I put that little amount of fluid in there, that you will see some people will have redness at the injection site, and some people will also experience pain or like muscle soreness in that area. You do have very few people who also will have like a low-grade fever. That is not them having the flu. And people mistake that and say like, oh, I get the flu every time I get the flu shot. That's just your body reacting to you putting that inactivated virus into their body, which is what we want. We want to see that. Looking at this, the nasal spray, remember that's the formulation that I told you is for the live. When you look at that nasal spray, these are all of the different things that they can have. Think of it as a live vaccine. The way I try to remember these are like the things that I would see if somebody actually kind of had the flu, like how they would present. They are going to react a lot more than the person who got the inactivated vaccine, okay? So the runny nose, the muscle soreness, fevers, like they sometimes will experience the whole thing. I have done the nasal spray before, and I literally experienced everything that was on here, okay? Versus when you're getting the inactivated, it's not that bad. I may sometimes have that low rate fever. So it just depends on your patient. But as a healthcare provider, which one of these am I not supposed to be getting? Live. Yes.
Now, how do you characterize the low rate?
That will vary depending on who you're talking to. On my exam, I'm going to tell you it is a low grade fever. I'm not going to give you a temperature and tell you to figure it out. I will write that that's what it is. Yes. Because I was freaking out when my daughter had her 105 and my pediatrician was like, that's fine. That's normal as long as it's not like that for more than a couple of days. And I was like, what? So y'all will learn about that when you do peds. But that definitely was not low grade. Anytime I see 100 and anything, I'm like, ah. So that will depend on kind of, so for me, I don't expect for you guys to interpret any labs. I don't expect for you to interpret or diagnose anything. I'm gonna always tell you everything, okay? All right, now we have these wonderful meds that came out and we started going crazy and we used to prescribe them a lot. And depending on who you talk to, some people feel some type of way about like if they actually work, and some people are like they swear by them. So we have our neuraminidase inhibitors, and essentially what we're trying to do is prevent or decrease the symptoms that that patient is having if they got infected by influenza virus, okay? The thing here is that they have to do this within 48 hours of them experiencing those symptoms. So if you take longer than that, essentially this medication, the virus is going to be going through its cycle to where the medication isn't going to be effective, okay? So your big thing that you want to make sure of here is when you're prescribing any type of Tamiflu is the big one that you're going to use. But if you're prescribing that, if I told you that it's been 4 days and I'm just coming in now because like I just can't deal with it anymore, you're going to say you wrote it out for quite a long time, you're at the tail end of this. Giving them this medication is likely to not work. It's not going to do anything for them because it takes time for the medication to actually work, but then their body has already fought off the big part, okay? So the sooner, the better when you're looking at giving your Tamiflu. So what we see is that it is supposed to decrease the duration of them having those symptoms by up to 3 days. Sometimes some patients don't see any benefit at all. I do see a lot of kids when we give them this that do, like they feel a lot better while they're taking the Tamiflu. But again, catching it within 48 hours is your big thing that you have to worry about. In the name, you see your mechanism, right? So it's inhibiting that neuraminidase, which is then saying, hey, it can't bud. So it's stopping that from cleaving or letting that virus bud off, all right? And then your different agents that you have, you see your oseltamivir, which is Tamiflu. This is a capsule. We can compound this in the pharmacy, so if you have a patient who needs liquid and we run out of the liquid because it comes in a liquid form also, or like a solution, we can make it for your patient. So if you see that it's out of stock when you're trying to order it, you can also be like, hey, can you guys compound it? We can compound it. Here's the Antiviral, which is Relenza. This one is inhaled. It kind of looks like an inhaler that somebody would use for asthma. And then you have your Primavera. This one we don't typically use unless somebody has like a lot of underlying health conditions and they're hospitalized, because this is an IV medication. So depending on how sick they are, we do have this as an option to provide our patients, okay? So we have 3 different kinds. You see that you have 3 different routes that you can use to treat your patients. The one that you're gonna see typically is gonna be that Tamiflu or your oseltamivir. This is just a picture showing you, hey, if I go ahead and I inhibit that neuraminidase, I can't escape or bud out of that cell. Now I'm just going to be contained within inside of that cell, which will eventually get engulfed by your body trying to fight off whatever that virus is. So if you can stop the cleaving, then therefore I can stop the spread of that virus, which then will help shorten the symptoms and all that stuff that they're having. So that's the mechanism in which this drug is working. Can't spread to any other cells, and then those macrophages will come and they will eat up that host cell that now has that virus contained in it. This is looking at your treatment and how long you are expected to see your patient beyond these medications. So when we have the Tamiflu, that comes in a box and it's already like prepared for them, right? So they just have to pop out their capsules and take their capsules every day. There's going to be a 5-day treatment duration for that. The same thing when we're talking about our Relenza. When you're looking at your Paramivir, that's the one where your patient would be hospitalized and they're going to be in the hospital. You will be monitoring them, but typically we only treat them for 1 day with that medication. Most of the time, your patients who are coming in with the flu, if it's not very severe, you can discharge them and they'll go with either your Tamiflu or your zanamivir. Remembering that your Tamiflu or your oseltamivir is the more common one that you're going to see. Post and pre-exposure prophylaxis. So prophylaxis, is that before something happens? Right? So when you see post or pre-exposure prophylaxis, if you know that somebody is going to be in contact with something, that's a typical way that we think about prophylaxis. But this post-prophylaxis is like, I've come in contact with somebody, or I'm in my college dorm and so many people have gotten sick. You know that it's a high chance that I'm going to get sick. Kind of how we are when we're in these classrooms, right? And we start to see the masks kind of pop up and you're like, okay, we already know that somebody else is going to get sick soon. So we can do what's called the post-prophylaxis and try to prevent that, because now enough people have gotten sick. So when you're looking at here, your best thing to do, which is why we always push this, is going to be your vaccine. Vaccinations is the best prophylaxis that you can have. Like we just said, our vaccine is 100% to make you prevent from having the flu. No, okay? But it can help some people to where they don't get it, okay? So that is our first option that we love, is to give them their flu shot. Make sure that they have their flu shot. When you see 2 cases within 3 days, that's whenever you're doing that prophylaxis, that post-prophylaxis. You're expecting that, hey, there's at least 2 people who have gotten sick and they're all in this confined area and we have diagnosed them with the flu. Now we can prophylactically treat the rest of the group who's there. So a lot of times when we see this, we'll see this in like nursing home type settings, things like that, where we're like, okay, hey, I had 2 of my residents get sick. Now I want to go ahead and prophylactically treat everybody else, because I know that these people probably have other underlying health conditions and I don't want them to have any type of respiratory issue with the flu, okay? And then looking at this, when you're administering, when the influenza vaccine is not available or not used, you can also administer these medications. If somebody has taken or had their flu shot and they got the flu, you can still potentially prescribe them one of these meds, because now you have a confirmed case that they do have it, and now you're just going to add on these oral options for them, or if they are severe enough, you have your IV formulation. So looking at your different agents that you have, your more common one is the one that I have up here first. So that is going to be your oseltamivir. You're treating that patient for 5 days. You also have your zanamivir, which is your Valenza. Remember, that one is the one that's the inhaler. And then you have your paramivir, which is your IV. These are your patients who are super sick. You're going to choose to admit them when they come in and they present to you with the flu, okay? We already talked about this coverage, right? Where typically when we have our vaccines, we're fighting A and B. We're doing the same thing when we're talking about our meds, we're fighting A and B, okay? Now, you see that all of these, you can use them for treatment and prophylaxis. That's all I want you to remember, is that they're used for treatment and prophylaxis. And then looking at your recommended form. So when we talked about this, just remember your cutoff of 48 hours, because I'm gonna try to make it very simple. Remember your cutoff for 48 hours. When you see this prophylaxis for your Tamiflu, I want you to remember that as well, because sometimes also you will give prophylaxis to your pregnant women as well if they are in contact with someone who has the flu, because you don't want them to be pregnant and then they get close to delivery and they have an active flu. They have flu at that time that they give birth, and then they get their baby sick with the flu. And that's a brand new baby who has zero immune system. That can be very, very hard for that newborn. So that's also why sometimes you'll see that we'll prophylactically treat our pregnant women if they are around someone who has the flu and they're later on in their pregnancy. So I just want you to remember that we can treat, we have prophylaxis treatment, we have these different formulations. I don't typically make you remember formulations, but I want you to kind of be aware that we have oral, my inhalation, and my IV, and then my oral and my inhalation are 5 days. My IV is just that one time that I'm running it. And then looking over here, these are your common side effects that you will see. Make sure that you are looking at your Valenza. If somebody has any type of respiratory disease, this is not going to be a great option for them, because I told you it's like an inhaler. So if I can't take in a deep enough breath, I'm not giving that medication to the site that I want the medication to go to. So if I have an underlying health condition that inhibits me from properly using an inhaler, it makes sense for you to say they should not be having an inhaler. So therefore, I would probably give them either the oseltamivir, or if they were super severe, I would give them the paramivir, right? But I'm not going to give them an inhaler because they already can't inhale deep enough, right? So try to link those two things together. That formulation is telling you why you shouldn't be using it in that population. And then your adverse effects here. Again, think about the formulation. Your formulation kind of correlates with some of these adverse effects that you have. So you can see that if they have an allergic reaction, they're going to have some edema to their face. It could also be to their throat area. And then you see the adverse effects. Just think about an inhaler again, right? I can have a cough. I can have sore throat. I can have anything that we talk about when we inhale. Think about your ears, your nose, your throat. You kind of think about those things together. Okay, so all of this kind of goes with the fact that it's an inhaler, okay? Everything else is like your basic stuff. Nausea and vomiting, we see that with everything. Diarrhea, we see that with everything, okay? This is your one that is related to the fact that you're inhaling. Don't try to remember these ages. I just want you to remember your 3-month-old and your pregnant women. It's why we like to use our Tamiflu, okay? All these other ages, I don't need you to remember that. Okay, RSV. So RSV is another bad virus that we've been seeing a lot more now. People like to post their kids in the hospital, hooked up to respirators and ventilators and IV. But now that we do have social media, now that we do have access to cameras and stuff a lot, you can see how serious these things are that have been around for a long period of time, but we just never took them serious. A lot of kids were dying from RSV. So it is something that you can kind of help with and try to prophylactically treat some of your patients, and knowing the populations in which you are going to go ahead and treat them before that season, that RSV season comes around. So just looking at it, just want you to know that it's something that's super serious. Not gonna ask you all anything from here, except for the fact that it is a very serious condition. You're gonna make sure that you're washing your hands to reduce spread, okay? The season is very similar to what we're looking at when we're talking about the flu season. RSV season is around that same time, okay? So this is just other background for you to kind of see, hey, this is just as serious as some of those other issues that we're looking at. 90,000 hospitalizations is a lot. And to think about 4,500 kids dying, that's also a lot, right? Because like, if we can prevent something, let's try to. Not everything is preventable, but some of this stuff, if we can just proper hygiene, we can limit how much it's being spread. So when you're looking at here, your big takeaway is that most of your kids are gonna be infected with RSV by the time they hit 2 years old, okay? Most of them are gonna have RSV. Usually it'll resolve in 2 weeks. Sometimes you will see that by the time they hit, bless you, by the time they hit 3 weeks, they should be coming in to see you, okay? So if somebody comes in the beginning of that RSV infection, you'll swab them, you're gonna see that they have RSV, and you're gonna be like, hey mom, guess what, your kid has RSV. They're reacting how they typically should, their immune system is doing this thing like we want it to, and most of the time we're not gonna treat them, okay? So when you're looking at this, this is gonna be for your patients when we start talking about treatments who have some type of underlying condition or they've been sick for a longer period of time, okay? So just keep an eye out on that. So from here, my big thing that I want you to know is they're gonna get infected with this typically before they turn 2 years old. And if we are worrying about treating our patients who have been sick for an extended period of time. So over 3 weeks, that's whenever you'll typically see somebody coming in like, my kid is still sick, okay? So, when I was telling you about us treating, I said, only in certain people are we gonna say, hey, I need to prophylactically treat this patient. I'm worried about them potentially having this super serious, super severe disease, and they may or may not be able to fight this off themselves. So, your kiddos who are less than 12 months old, and this is at the start of that RSV season. So between that November timeframe and April was where we saw like our peak in our RSV cases. So if they're gonna be less than 12 months old by the time that November timeframe hits, then you have all of these different options as to where you're gonna say, I need to prophylactically treat them. So if they have some type of issue to where they already have issues breathing, right? Because this is more of a respiratory type of infection that they have. So I just try to remember this as anything that's affecting their lungs, anything that's affecting their breathing, these are my kids that I'm going to try to prophylactically treat. So CLD, the congenital airway abnormality, muscles, right? Neuromuscular disorder. I have issues with my muscles working properly, which then means that I could potentially have issues with my airway, okay? And then this born less than 28 weeks, 6 days. So born less than, I guess we would say, 29 weeks is a cleaner way, I guess, that we could kind of say this. So if they were less than 29 weeks, that means that they were premature, and they're going to be in this time frame, in that November time frame, then I'm going to probably also try to prophylactically treat them. Reason being is that because they were so premature, their lungs may not have been fully developed. So I'm still worried about them not having enough strength if they get sick with this with RSV to fight off that infection and survive the infection. Okay? So the way that we're remembering to treat our less than 12-month-old kids at the time of RSV season is anything that's affecting their lungs, we're worried about them. We're prophylactically treating them. In less than 29 weeks, if they were born at less than 29 weeks, we're also going to try to treat them, right? Because we're worried about their lungs. Your 2-year-olds, these are your patients who are going to be very, very, very sick. They're probably going to be already in and out of the hospital a lot. So if they have any type of they're immunocompromised, right? Because now when we talked about people who are immunocompromised, they can't fight off anything. They're going to rely on our drugs. They're going to rely on kind of being like in a bubble, in a sense, right? Because any little thing that comes their way could be super harmful to them and sometimes even deadly to them. if we're talking about transplanting their heart, they have a weak heart, right? Again, very concerned about this patient. Also, they're gonna be taking medications so that that heart transplant doesn't reject. And most of our meds that we do with that are also gonna make them immunocompromised, okay? And then looking at your CLD or prematurity, so this is essentially saying like, hey, they were a premature child and we had them in the NICU and they were receiving any of these things. So like, but they have to still be less than that 29 weeks, okay? So just think of if they were sick enough to be in the NICU and we had to help their lungs develop more. Sometimes we do steroids, different things like that. We had to help them breathing in their first part of life. We have up into 2 years where we're worried about prophylactically treating these patients. Less than 12 months for any of our other like less severe lung issues that we were worried about. Our options that we have. So when we're looking at these medications are going to be kind of expensive, and they are effective. They're very effective medications and they're worth it, especially if we can keep somebody out of the hospital. That 90,000 patients in the hospital is a lot. That costs us a lot. So when you're looking at this, remember RSV is that respiratory infection. So when we're prophylactically treating them with something like palivizumab, we are trying to prevent them from having RSV. So we'll give this prior to that season, and then you also, if they're in the hospital at that time, so let's say they were born at that time, or they're in the hospital for some other reason, you need to try to give them this medication like 48 to 72 hours before we discharge them and get them out. So when you see MAB on the end of things, what you want to remember is that it is a monoclonal antibody. So M-A-B. Anything that is a monoclonal antibody, on all of the ends of those names, you're going to hear MAB. Okay? So MAB means monoclonal antibody. So what this is doing is this is essentially trying to bind and make sure that that virus does not even get into the cell to hijack my host. I'm trying to prevent it altogether. Okay? Not saying that it'll get everybody 100%, but this is like you trying to cast a wide net and get as much of that virus as you can, not infiltrating the host. Your clinical use, we see that we have our prophylaxis that we talked about. Don't worry about remembering this dose. Just understand that this is an infusion that they're going to have to come in and get several times. Okay, they're going to have to get that injection several times during that RSV season. And then looking at this, your first dose should be administered prior to, especially if you know that you can't get them in. If you can't get them in, then it needs to be at the very start. The reason why we're saying prior to, and most of your patients will come in on time how they're supposed to. But why we're saying prior to is because of the word prophylaxis, right? I want to do it before I'm seeing that increase in the risk. This does not mean that we catch everything, because I can have RSV floating around anytime, okay? So I'm just trying to catch as much as I can. Looking at another option that we have, this is going to be your respiratory syncytial virus vaccine, or Librisvo. This one is a newer medication. This is the only one that you're going to see that is approved for your pregnant patients. Okay, so your only FDA-approved RSV vaccine for your pregnant patients. When you're looking at your mechanism, again, just trying to decrease that how bad this infection is going to be for those patients. So inducing that immune response that you're going to get from that from the virus, essentially. Okay, so you're trying to say, hey, I don't want this infection to be that severe, especially while someone is pregnant. So you will see that later on in the pregnancy, a lot of your patients will get this. When I was pregnant with my last one, they're like, oh, do you want to get the RSV vaccine? I was like, absolutely not. They're like, well, if you don't get it when your kid is born, we're gonna make your child get the vaccine. And I was like, I will get it. And it did not feel fantastic. It was horrible. But it was worth it because I was like, man, I can't imagine if they were to do this to a baby. But the dose is probably smaller and it probably doesn't hurt as bad. Kids are very resilient. So looking at your prophylaxis that you have, so your older patients, you're definitely worried about them. So you see that this says 75. But once I get to lower this dose, or lower the age, remember when we were talking about all of these different underlying health conditions, like if I have any type of respiratory issues, I'm more worried about those patients, okay? So you see that if I have any type of respiratory issue, if I have any type of heart issue, which we talked about, like those patients who are getting a heart transplant, right? If I have any type of diabetes, remember we have that sugar floating around everywhere and it's just tearing up all of the things. Diabetes, you're gonna see it all over everything. This is one of those disease states that we hate to see coming because we know that they're likely to have some type of comorbidity. They're likely to get some other type of disease as well. And then looking at so that's why you see that age drop for those patients because we're more concerned about them and not being able to clear that infection. Talked about your pregnant women, seeing that that's kind of towards the later end of their pregnancy. You try to catch them and get them between that 32 and 36 week window to vaccinate them. And then your 18 years or older, if they have any of those underlying disease that we talked about before, so like the fact that they're premature, regardless of if they catch up or not, a lot of the times we always kind of keep an eye on those kids. Most of our premature kids end up being the biggest adults. But a lot of times we still watch out for them to make sure that there's not anything else that we're missing or that has developed at a later time. So you see your premature patients, your cardio, so the same things keep popping up again as to why we keep dropping that age and saying, okay, well maybe we can let the 18-year-olds do it. Okay, well maybe we can let this 60-year-old, but for everybody, we're looking at who are over the age of 75, they should be getting vaccinated. This is a one-time thing, so they don't have to continue to get it over and over and over and over again, okay? I have seen where somebody ends up getting RSV after they have gotten this injection. Sometimes some providers or the patient may say, hey, can I have one more like as a booster type of thing, but it's not anything that's in guidelines saying that we have to do that. Adverse reactions, very basic things, but one that we already seen. So again, just like we talked about with the flu shot, if I give them that injection, they may have some redness at that site, they may have some pain at that site, so just make sure they continue to move around. And then looking at the increased risk of GBS in these patients, this is an FDA warning, so they are worried about it, right? So just make sure that you're understanding that that is definitely something that we need to watch out for, especially if the patient has a history as well. So, big thing with your Abrezvo is that I can use it in pregnancy, and then you're looking at the fact that you have your different age cutoffs. So if somebody has any type of underlying issue, we are worried about them. Cardiac, pulmonary, we're worried about their ability to fight it off, and then the FDA warning. Looking at another one that we have is called Arexvy. So you'll see this generic name looks very similar. So your brand is kind of like if you're trying to take the exam. So you see respiratory syncytial virus vaccine, two different brand names, right? So slightly different mechanism slightly different mechanism of action. But if you just remember that it's trying to get that immune response against RSV, that is good enough, and that you're understanding that this is a vaccine. I'm not going to look at the different F protein that it's binding to and all that stuff. Our clinical use, just making sure that we're again giving this prophylactically to our patients who we think are going to be at an increased risk for having that RSV. We do see now that that level that we dropped our Abrezvo down to, that 60, this is now where I can automatically start vaccinating my patients without any of those other caveats that we talked about, their lungs, their heart, okay? So this is a different age group now that I can give and offer this medication earlier. And then you see your 50 to 59-year-olds are those ones who have any types of underlying health conditions. So the heart, the liver, the respiratory issues. And then again, only one dose needed. And what you don't see here is us giving this to pregnant patients, okay? So this one is not for your pregnant patients. Adverse reactions, when we give this, a lot of the times we tell our patients to stay for us to observe for at least 30 minutes to an hour, depends on where you are, because they can have that anaphylactic reaction. Still has the same kind of common adverse effects and that your FDA warning for the increased risk of that GBS. Okay, so these two look very familiar. Your Abrezvo and your Arexvy. The only difference is you're looking at the different cutoffs. So your Breezeville is 75, your Arexvy is 60. And then looking at your Breezeville as being the only one that's FDA approved versus your Arexvy is not for your pregnant women, okay? And then if you look at the adverse effects, the warnings, all that is very similar. I told you for your mechanism, if I ask you, I'm not trying to make you remember pre-F versus protein F. Just remember that you're trying to induce the immune response, and that it's a vaccine, okay? We're gonna be injecting them with it. All right, your ribavirin, this one, we're going to have our patient inhale, so it's kind of like a nebulizing type of thing. Your mechanism of action that you're looking for here is to say, hey, I don't want this virus to replicate. Remember, the more your virus replicates, the higher that viral load, and then the more likely we are to see that it's gonna continue to spread. Your patient will continue to decompensate. Remember that this is a respiratory infection, so this makes sense as to why I can give them that ribavirin for inhalation, right? I'm gonna get to that site, I'm gonna get to the lungs, I'm gonna get to that respiratory tract a lot faster. So you see here, we have lots and lots of benefits because depending on how far your patient is, sometimes we end up just doing supportive care, right? Where we're trying to be like, okay, we know that now this is on the downward end, we're trying to give them oxygen, we're trying to help them breathe, but they're so like, their lungs and their respiratory tract is so compromised, sometimes there's nothing that we can do about it. So that's why you see this increase in oxygenation is a big deal because that's what a lot of our patients end up suffering from, and that's what a lot of them can end up dying from, right? Because if they're not getting oxygen to their body, that's no good. Looking at your clinical use, a lot of the times, and where we started to see this pumped out a lot was our PEDS patients who were getting hospitalized from RSV. They were sagging very low with their O2 they were super low, and so we were like, okay, they came up with this med, works pretty good. Again, it is not 100% cure that your patient, if they do end up on this medication, that they will recover. Looking at your treatment of the severe infection, so even if they're not super decompensated or anything like that, I can still say, hey, I want to try to give this because I see that I'm trending in a negative way. So any of those underlying health conditions as well, I can also try to start this ahead of time, like getting ahead of the curve. You see that it reduces the mortality in your high-risk patients. So our high-risk patients are those people that we were saying were immunocompromised. We were saying that they were premature, cardiac issues, lung issues. We see that there's an increased benefit or mortality benefit. Now, in your normal patient like you and me, if you're giving it to me, you may not see that same increase. So just understand our high-risk patients are the ones who benefit the most from this, but doesn't mean that you shouldn't give it to me if you make that clinical call that, hey, I still want my patient to have some ribavirin, okay? But the mortality benefit is greater in those patients who have those higher risk disease states that we talked about. And then when we're looking at this, most of the time we're not seeing it in kids. I think I've seen it used off-label in an adult once, but we typically are gonna see this in our kids. And then your adverse reactions look very familiar. Make sure that you understand, because of how we are giving it, that there's a possibility of me eliciting or causing a bronchospasm in my patient. So remember, if I'm inhaling something, I'm getting to that site, I have the increased chance of getting that bronchospasm, and then you see some little skin irritations and rashes, so not horrible. When we looked at this with our animal studies, we do see that it was teratogenic when we were talking about the rats. But again, this is not something that we're typically using in adults, in hopefully our little babies. Our babies are not trying to get pregnant at that time, so when we look at some teratogenic medications, we're looking at that time. That will then, it will leave their system by the time that they're trying to become pregnant. So in an adult who is of childbearing age, this is not something that we should be using because it's not very well studied, okay? Let's take our break, let's do 10 minutes, come back.
Says the guy with the pop.
Good or what? Was it good?
Bro, I was standing next to her the other day and I was doing this and I was like, oh, no more rocking for me. I'm about to fall asleep for me. Slow snail spot.
We have for done in December. I wouldn't put everything.
Yeah, it's Monday, Friday, Monday, Friday, Monday, Friday.
I want to say one of the hardest tests. The hardest test is going to be clean lab exam.
Yeah, just we have what, like 5 weeks of studying for that bitch.
Yeah. And then it's like right before the break, it's the last thing.
Yeah, but if you do that,
It's going to be the hardest. But I ain't going to say.
pass that. You just got the tester.
Yeah, it was. That goes. Oh, this is just a 287. Dude, I broke 300, dude. I was at like 320.
Haven't had the right.
Pretty good. There's a photo.
It's not gonna be a good weekend to get ready for the class. Got that fun skills lab.
Hell yeah. Yeah, let's go. Great. You see like that when you did? No, okay. So what you're looking for is you don't see anything on the X-ray. Now you're trying to see is there any that's what you go to So
Alright, party people, let's finish this up. Okay, this is what I was telling you about, the supportive care that sometimes we'll see, with our patients who have RSV. So it's not. These monitors are safe. Okay. When we're looking at this, a lot of the times, and this is why we were seeing such a huge awareness push with RSV, because we didn't have a lot of things that were being super effective. Yes, we have these meds, but sometimes we're not quick enough in giving these meds. So a lot of the times we had our supportive care that we were giving. Patients were ending up on ventilators. We were trying to push oxygen, all of the things, and sometimes, like I said, it wasn't enough. You also have all of these different things that are down here. They're listed here because they don't work. But when we think about it, in our brains, it would be like, hey, I could probably reach for these things. So all we really have is supportive care and our prophylactic treatments that we were talking about before, or our patients that we were treating and they were super severe. These are things where we would be like, oh, let me give them a beta-2 agonist, something that we would typically give for our patients who have like asthma, COPD, right? But here, this hasn't shown us to do that it's effective at doing anything. Your corticosteroids, same thing. We haven't seen that they're effective. And then when you're looking at your antibiotics, are antibiotics doing anything to a virus? No. So the only time that you're going to benefit from giving an antibiotic is because they have some type of bacterial infection in conjunction with that viral infection. Okay? So all you're remembering is like, yes, this is what we're trying to use that works. These things that may seem like oh, let me try this. These things we have not found improve any of their outcomes, their clinical outcomes with RSV. All right, herpes virus. So when we talk about herpes virus, we have two different types. Treatment and prophylaxis, as far as like if somebody feels like they're having an outbreak or that they're about to experience an outbreak. We can also do prophylaxis to where they'll take medication every day. Thing I like about this little section is that they're the same 3 drugs that you're gonna have to remember. And we use them to treat any different type of our herpes viruses that we have. So looking at our chart here, we're working on trying to stop that copying or incorporation of that virus into our DNA. When you look at valacyclovir is just a prodrug of acyclovir. So whenever it gets metabolized, it's going to get metabolized into that acyclovir, which is also going to help us do some action. So my different agents that I have available to me, you see your famciclovir, acyclovir, and valacyclovir. The one that you are going to see used more likely is going to be your valacyclovir or your Valtrex. Again, we talked about that mechanism, so essentially we're trying to stop that viral replication, okay? We don't want it to continue to replicate, so what we did is we made this drug that kind of mocks a functional group and it'll stop that elongation, okay? So that's what it's doing, it'll stop the elongation of the virus. Looking at our spectrum, told you that we had 2 different types of herpes simplex virus. So we have type 1 and we have type 2. And then looking at your moderate, you see your VZV or your varicella zoster virus, which we're also going to talk about. The big thing to make sure that you remember is that this is not a cure when we're talking about either of these viruses. This is just helping whenever they have a flare, whenever they have an outbreak. This is kind of shortening the duration of that, or completely suppressing it. When they come to you, a lot of the times, especially if it's going to be an HSV virus, a lot of the times their symptoms are going to be worse the very first time. And then after that, when they continue to have like those flares or those outbreaks, it may not be as bad. You also have like cold sores. Cold sores can also be considered HSV. Okay, so just thinking about this, understand that if somebody stresses out a lot and they continue to get cold sores, you can put them on prophylaxis as well to make them prevent those cold sores from happening. Looking at your clinical use that you have, effective in treating your VSV, effective in treating your HSV, these are just great medications that we have for these issues. Adverse effects, most of the time, they're very well tolerated. The big thing that I hear on the outpatient side and what people are typically coming in for is headaches, which is not even on here. That's the bigger thing that I hear people complain about. So nausea, vomiting, those CNS effects that you see, tremors and seizures, not very common when we're talking about them, but it is a possibility for those to happen, and they're very serious things that can happen. So what we typically tell people while they're taking this medication is just to make sure that they're staying very, very well hydrated, especially if they're doing it prophylactically and they're taking it every day. A lot of water is very, very, very good for them. So GI issues, disturbances, okay, rash, headache, you can see that in there, so write that in there because a lot of the people that I do see, that's what they're typically complaining about. All right, our varicella zoster virus. When we're looking at this is good old chicken pox, is what we used to call it, right? And so when you're looking, you have this, what we were considering a childhood disease, and then it goes dormant after you get your chicken pox, and then it can be reactivated again later because remember it's a virus and it just hangs out, and it gets reactivated, and then we have our wonderful shingles. So looking at what we have now, we're now having these different vaccines that we can use. Back in the day, we were having chickenpox parties to just try to get it out of the way, right? Send your kid over, oh, your kid has chickenpox, great. And we send my kids so they can get chickenpox and we can get this out of the way. My mom sent me to school with chickenpox. We were living in Florida and she just sent me to school with long pants and a shirt. And I was scratching all day. Long pants, long t-shirts, scratching all day. And the teacher was like, why are you, it's hot outside. Like, what are you doing? You never wear. And I was scratching like a crazy person. And they called my mom and she was like, why were you scratching in school? Girl, I had chickenpox. Come and pick me up. and we have our Varivax. So looking at your Shingrix, this is the one that's, bless you, helping with your herpes zoster or your shingles, and then your Varivax is the one that's helping more so with the varicella and our chickenpox. So we try to give it to our kids when they're very young now so that we can prevent that wonderful outbreak that we were typically seeing. And then we'll give them another dose. So they have their initial and then they essentially have a booster. With your Shingrix, this vaccine has been very controversial as to like, is it effective, is it not effective? We still recommend it for any of our patients who are over the age of 50, okay? They can get it here, they can get it at Walgreens, they can get it at CVS. We definitely recommend it. When people have the vaccine, it is thought that it helps if they do have an outbreak for it to not be as severe. People tell you that shingles hurt very, very bad. I've also seen that a lot of people, like I've had 2 friends in the last year in their 30s get it. So like the age seems to be dropping, so I'm wondering if they're gonna start to kind of decrease this age of when we typically would recommend it. After someone has an outbreak, if they haven't reached that age of 50, where we would typically recommend this, we can give them the vaccine after they've had their outbreak. There is no specified window that we are looking at. If they're having an active shingles outbreak, you giving them the vaccine isn't gonna make it go away. Let them go through that outbreak, and then you can give them a vaccination afterwards. The thought is that we're not rushing at that point because their body is making antibodies at that point to that virus anyway. So giving them the vaccine at that point isn't doing anything. It's not helping them. So just wait until they're done with their outbreak and then you can cover them. This is just essentially a picture of kind of what that looks like, and you were seeing that it was a very effective vaccine, but it's not something that's 100%. And those patients who ended up getting infected, they did say that they felt like their symptoms probably could have been a lot worse had they not had that vaccine. Okay. Looking at my goals. My goal is to always make sure that my patient is comfortable. That's essentially what this is saying. So I want to try to decrease the spread of this virus. I want to try to decrease the pain that patient is going to have, and see if I can prevent that post-herpetic neuralgia that patients will feel. So sometimes even after they've had the outbreak, they will have like this remaining like residual nerve, like neuropathy pain that they feel from them having the shingles. And sometimes people will get placed on other medications to try to help with that post-herpetic pain that they're feeling. And then looking at this, we want to try to start it again as soon as we possibly can. As soon as your person knows that they're having any type of outbreak, any type of shingles, we want to try to treat them. If we're doing treatment, we want to try to treat them within that first 72 hours. Prophylactically, we're waiting until they hit that age marker, and that's what we're trying to get it to them. Looking at my different therapy that I have. So we already talked about these, valacyclovir, famciclovir, and acyclovir. Don't need you to remember the duration, I just need you to remember the drug options that you have. Remember we talked about our vaccines, right? If I have a vaccine, then I may be able to help decrease how bad these symptoms are for the patient, but I'm not gonna do anything effectively with a current outbreak. I'm gonna use these medications, these oral medications for that current outbreak, okay? And I'm trying to get these started within 72 hours of that person having that outbreak, okay, of those symptoms happening. A lot of times people don't know what they're experiencing, especially if they never had a shingles outbreak before. So they will start to feel like these prodromal type of like tingling and itching, and like they'll start to see maybe 1 or 2 little bumps, and then all of a sudden they'll have like this full-blown flare. So just kind of ask them, do they remember when they started? Looking at our HSV, we have several different types of HSV, right? Our 2 that we talked about. So you have your oral and you have your your oral and your gingival. Well, that's your oral and your vaginal, or genital, I guess I should say, because men can have it too. So genital. When you look at your HSV 1 and 2, just because someone has, when you test them and it comes back and it says HSV1, does not mean that it can't be in another location, okay? So you can have HSV1, which is typically in the mouth, but it can also present in the genital area, and vice versa, okay? So when you see HSV2, that's typically in the genital area, but again, doesn't mean that you can't see it in the mouth, okay? So that's the difference between our two. No matter which type they have, I still have my same 3 medications that we just talked about. For our shingles outbreak, I still have the same one for my HSV outbreaks, okay? Again, all I need you to remember is the drugs that you are using, okay? When we are looking at this is like your fever blisters that patient can have. Again, remember I was telling you if that patient continues to tell you like, hey, I keep getting these, or hey, I don't want to have this sore on my mouth, they can typically feel when it's about to happen. You can have this prescribed for them and be on their profile, and they can always come and pick it up if they need it, okay? So that's what this is for. They would take it whenever they start to feel those symptoms. And then this is your genital herpes or your HSV2. Or looking at this, again, remember your first outbreak that they have is typically going to be their worst one that they have. So we're typically treating them for a longer period of time. Then whenever I'm having my recurrent, I don't have to treat them for as long, typically up to 5 days. If I give them a higher dose, that's where and they're taking it twice a day, that's where you see the 3 days at. So it depends on the patient and how they want to take their medication. So what I want you to remember is essentially, I have, for my first outbreak, I'll tell you to remember the duration of it. For your first outbreak, 7 to 10 days. That is their first time. That is you trying to get this medication in their body, because remember, this is the worst one. And then on that, when they have it again, it could be years, it could be a month or 2 after they had their first one. You don't know how often they're gonna have an outbreak, okay? So that's why I typically will tell a provider, hey, when you prescribe that first one, also give them like a refill, just in case. And then no refills after that, so that they can come into you and you can have a conversation with them on how to manage. But you don't want them to have their first one and no meds on profile, and then they have another outbreak and they have to wait to get back into you, okay? So that's why I'll typically say, if you diagnose somebody, you give them that first one to treat that outbreak, and then you can give them a prescription on file for when or if that other outbreak happens. And then this is your suppressive therapy. So for your patients who are like, hey, I don't want to ever experience this again. I had an outbreak, I had another one, I'm good, I don't ever want to know what that feels like anymore. So these people are going to take this every single day to suppress potentially having an outbreak, okay? Again, your more common one that you're going to use is going to be your valacyclovir, okay? We also think that in those people who are having this suppressive therapy, it does not necessarily mean that you could still be shedding the virus even though you don't have an active sore, okay? What we're thinking with these meds is that if I'm giving this to them in a suppressive manner, that it could be potentially decreasing how much that person is shedding, therefore I'm decreasing the amount of transmission. So just kind of thinking about these are your 3 different options that you have. Your first one you're gonna treat. Your second one, you can continue to just like spot treat that person. So let's say they only have one outbreak every 3 years or every 9 months. They may not want to take a medication every day for that. They may want to just spot treat themselves, and you can prescribe those medications for them to spot treat when they have that outbreak, okay? They don't have to take something every single day. Okay, HIV. When we're looking at our HIV, just understand that ultimately this is something that a lot of people are now living a lot longer with. HIV does and can progress to AIDS or acquired immunodeficiency syndrome, and that's what we're trying to prevent with our medications. We're trying to say, hey, if I can manage you, if I can get this viral load under control, you're less likely to have a lot of diseases that can potentially worsen you and hit you to, or push you to that AIDS stage. What you're going to be monitoring is going to be different viral loads in your patient. So just big thing that I want you to remember here is that if we have no medication on board, our CD4 cells, which are going to try to help fight off the bad things, they're helping control our immune system. So if I continue to not treat, those numbers are going to continue to plummet, and therefore your patient is going to be more immunocompromised, right? Because they don't have anything that's helping them fight off anything. So that's what we're looking at when we're looking here. Your transmission is also very important as a healthcare provider for you to remember how they are transmitting, okay? Blood, semen, anything that has blood in it. rectal fluids, breast milk, all of these things are what we're worried about. When somebody coughs, unless they're coughing up blood, you don't have to be like, oh my gosh, I got HIV. Like, because that's how we used to think before. We had no idea how the transmission was occurring. So as a healthcare provider, you just need to be careful in protecting yourself with any of those bodily fluids and like blood. That's the big things that we're worried about. And we'll talk about how we treat ourselves if something happens to us. This is more just background information for you guys to look at. You're going to learn about these things, but looking at all of the different stages, and as they continue to progress and they get to AIDS, that's because that CD4 count has dropped quite a bit, and then we'll see a lot more infections kind of taking those patients out because they're now very immunocompromised. Okay, so I put the FYI on this one for you to remember. And then this is just showing you how they initially started, right? So this is before I had the HIV infection. Now I'm infected, and these the virus is kind of taking over. And then this is whenever they can live this way for years. And some people can stay right here for years. Okay. Over time, especially if resistance starts happening to our meds, or they stop taking their meds how they're supposed to, that's when you can start to see this full-blown AIDS that can happen in our patients. So this is, again, just showing you all of the different opportunistic infections that can happen in our patients that you're likely to see. The longer that they're infected with HIV, the more likely you are to see some of these opportunistic infections come on. So these are like our earlier on, and then this is kind of where you start to see towards the end of time. And so this is us when we were talking about our patient who decided, he was on other antibiotics also, but decided that he no longer wanted to treat, and we did a transition of care. He also ended up having MAC also, which of course is very slow, very hard to treat, and he was just tired. So these are AIDS-defining illnesses that you will see are your opportunistic infections. Okay, my goals. My goals are to essentially make sure that I can get that viral load down as low as possible, so less than 20 to 50 copies, and I want my CD4 count to be as high as I can get it. So I'm just trying to make sure that they have a good immune system, and that's what I'm doing with my drugs because I'm decreasing that viral load. If my viral load is low, I can keep working, okay? Minimizing and this keeping it simple is essentially telling us like, hey, if you can add on, because your patients are going to be on several drugs, we'll talk about our backbone. But what we're trying to say is like, I want to keep it as simple as possible so that I can make sure that I have my patient buy in. I can make sure that they're actually taking their medications, okay? So I want to simplify their regimen as much as possible so that they're adherent. So we have combination pills, we have all these different types of things to kind of keep our patient on track and adhering to our regimen and not having such a heavy pill burden. When drugs initially came out, there was heavy pill burdens. Okay, here are all of our different medications that we have, all right? When we look at this, we see that there are several different classes, 7 of them. When we talk about our classes, I'm going to try to give you some little hints to kind of remember it. But what I want you to remember is the big backbone that we're essentially having. So typically, you're going to use 2 drugs from here, which is your NRTI, or your nucleotide reverse transcriptase inhibitors. So your NRTIs, and you'll typically use 1 integrase inhibitor. Okay, so 2 of these and 1 of these is usually what we're using for our backbone, and I'll have a different picture that kind of goes over this. When we're talking about our different meds, you'll see that your protease inhibitors, so your PIs, these are typically used with a booster that you would have, and then these are our boosters that you'll typically see paired with your PIs. So these kind of go together. Okay. So far we have 2 NRTIs, so 2 of these that we would pick, and 1 of these as our backbone. If you pick to use a protease inhibitor, most of the time your protease inhibitors are going to come with a booster. Your more common booster that you use is going to be that ritonavir. Okay? So, let's look at some of these drugs.
Ma'am?
Yes.
Did you say it was just 1 of the protease inhibitors? And then 1 of
You
the
can't.
inhibitors?
So, for your backbone, I'll go over your backbone better on the other side. But usually if you're using a protease inhibitor, most of the time you're gonna have a booster with it, just one.
Just one to one on that one.
Yes, yes. So like you would pick one of these drugs and then you would say, hey, I need to boost it with ritonavir. For our backbone, because we're on this slide and I want you to remember 2 of these, 1 of these, I will explain it to you on the next slide in more detail. So 2 of these and 1 of these, because I just want you to keep the flow together. So to try to remember these, you have your NNRTIs. Your NNRTIs have vir in the middle, so that's why I underlined in bold your vir, and it's right in the middle of your word. Okay, vir. When you're looking at your protease inhibitors, they have navir at the end of them. So you see all of these say navir at the end, which is why I underlined and bold that. Your integrase inhibitor, you have tegrase right here, so you can kind of say, oh, these say tegra, like tegravir. So I'm integrating them, so they have tegravir in the name, and all of these have that at the end. And then your fusion inhibitor, infuvirtide, so I underlined that because it's like it has the FU also in there. So it's trying to stop the fusion of that virus with your host. And then your CCR5 antagonist, I think about Marava-Rock, it ends in rock as like something that doesn't move. It's against being moved, so your antagonist. So that's how I remember my CCR5 inhibitor is because it's a rock. It's heavy, it's hard for me to move. Your boosters, you have 2 of them, just kind of remember those 2, and then your NNRTIs is just everything else. I didn't have a nice way for us to remember this because they were all kind of over the place, okay? So just look at what I kind of bolded and then associate them with the NNRTI. It will not be tricky if I said, hey, which class does this fall into? Try to remember this and say, okay, these go to my NNRTIs. My tegravirs are my integrase, okay? My rock, it doesn't want to move, so it's my CCR5 antagonist. Try to remember to just do these instead of trying to remember every single drug name, okay? Just remember your endings. I will not make up drugs, okay? So if you want to remember every single drug name, fantastic. If you remember these endings, you should be okay. And then just know that these are kind of your everything else. So if you can't pin it to this, you're like, oh, it must be my NRTI, okay? Yes?
And for the background one, you said you pulled 2 from, is that the whole protocol or just the top?
Just this top, your NRTIs. Yes, ma'am. Okay, so this is what we were just talking about. So looking at this key can kind of help you remember what you're looking at and what you're trying to do. So in our patients who are going to, you may see them, they're diagnosed, they're new patients. That's why you have your naive versus your integrase inhibitor base. Don't really worry about it in that sense. When I'm looking at my darunavir with my ritonavir, this is a protease inhibitor, so remember I told you that you're going to usually add the booster to one of these. Okay, so that is what you're seeing here, and then I still have 2 NRTIs. No matter what regimen I choose, I have 2 NRTIs, 2 blue ones, okay? So I can either use that protease inhibitor, or I can use an integrase inhibitor. These are just examples. You don't have to remember this. You can just say, hey, I need 2 NRTIs, and I can have either a protease inhibitor, or I can have an integrase inhibitor. And if you remember the way that we did the names, I can just give you that name and you can be like, yep, here's my 1 integrase inhibitor, here are my 2 NRTIs. Make sure that any regimen that you're using has 2 NRTIs on it. If it doesn't, then we're increasing resistance. So they're usually on these meds because we're trying to say, hey, I want to make sure that I don't confer resistance. So that's why they're going to be on multiple drugs. So 2 NRTIs, they can either have that protease inhibitor or they can have an integrase inhibitor, okay? Now, when I look over here, I have some of my drugs that are gonna have pre-made formulations and some of them don't. What I want you to remember is gonna be these 2 things that I'm gonna point out to you. Your patients who are HLA-B5701 negative. These patients, you wanna make sure that they are negative. If they are positive, then they cannot have a bacavir. bicavir is your problem here. So essentially what HLA-B 5701 is, it has like this very serious hypersensitivity reaction that your patients can experience. And so we're trying to say, hey, they can have these life-threatening issues occur if they are not negative. So if I tell you somebody and you do that test and they come back and they're positive, you are trying to make sure that you do not include abacavir as one of your NRTIs in their backbone. Okay? Because they're going to have a what type of reaction? Hypersensitivity reaction. We want them to be negative to this. The other thing that you're watching out for is if you see your cobicostat, they need to have a creatinine clearance that is over 30 because the drug will not work. The cobicostat is one of our boosters that we have, okay? So we need to watch out for that creatinine clearance, all right? That is the big thing from this slide. You do not need to remember all of these names. If you can remember the little tricks that I have underlined and bolded, and then remember I need 2 and then 1. 2 and 1, then you should be okay. The 2 things on the side that you're worried about is your HLA-B 5701 negative, and you want to make sure that that creatinine clearance is good. All right, these are your side effects that you have that are going to that you're watching out for, and this is for that entire class that we're looking at. So all of our NRTIs, these were our everything else's. We were worried about lactic acidosis. This is increased with some of our other medications that a patient could potentially take. I just want you to remember your lactic acidosis is essentially going to decrease the amount of O2 supply that they have, and it can, then you see some more of these issues happen, like hepatic issues. So just think about lactic acidosis, hepatic issues that you're seeing, and neuropathy, okay? Those are your big things that you're looking at here. If you can remember, like, grouping them together, because some of you are asking about that, like, how do I remember all these side effects? I try to group stuff together. And I'm like, okay, cool, if I see anything that's worried, hepatic issues, okay, I can pick that thing. Like, that's dealing with that drug. I don't try to remember every single one. And then the lactic acidosis. Looking at this, we don't have a lot of interactions with our SIPs because some of our drugs that we talk about, we're going to be worried about our SIPs. And then your HBV, making sure that your patients know that any patient who is on any of your antiviral medication, they should not just abruptly stop it, especially if we're talking about treating HIV. They need to always be on medication, okay? Because our goal is to always keep that viral load down. But if they have hepatitis B, we're definitely worried about them because they can have a flare-up. But again, our goal is to make sure all of our patients stay on their meds. Looking at our options that we have, specifically our NRTI, so you have your emtricitabine and your tenofovir. These are 2 very common medications because they are, and they do come in a combination, which you'll see called Truvada. And so this now allows that patient to take 1 pill. We talk about Truvada a lot because we'll talk about like PrEP, and this is one of those drugs that those patients can take. So looking at your adverse effects, just kind of go over them here. The big thing that you can also see is that hyperpigmentation that some of your patients are going to have, especially, and you'll see it more, I guess I should say, not especially in your African American patients, okay? And it's on the palms of their hands, they'll start to see them darkening. We typically see this when somebody is on them for a longer period of time, okay? And then looking at your adverse effect of your tenofovir, your big thing with your tenofovir is renal toxicity. So try to remember that it has that T in it, so you'll see that renal toxicity that can occur. And then it takes the bone away. T takes the bone away, so that's where you see the decrease in their BMD. They both do this, but I'm more likely to see that BMD loss in my tenofovir than any of my NRTIs that I have as a class. This is our higher offender for that. And this is something that you will monitor when you see a patient that is on Truvada, because most of your patients are going to be on Truvada. We do monitor this. ID definitely monitors those patients. And they don't, sometimes they won't put refills on their meds because they want to come back and get those labs to make sure that their BMD is okay and that their renal function is fine. So those are the big things from there. This risk increase if we're typically worried about. We're saying that, like, if they have any of these underlying conditions, they're more likely to see that renal toxicity occur. So that's why we're saying make sure that they're drinking. If I talk about NSAIDs, we'll get this next semester, but our NSAIDs can mess with our renal function also. So if they're using these together, that's why you're likely to see also an increased risk in someone having renal toxicity occur. Our integrase inhibitors, so remember these were our ones that said dolutegravir, so you see raltegravir, dolutegravir, elbapentravir with the cobicostat, and remember, what was my creatinine clearance that it needed to be over? Okay, and then your victegravir. And then looking at my clinical usage, I'm not gonna ask y'all anything like that, we're talking about HIV, okay? And then I'll talk to you specifically about the ones that are PrEP and PEP. So just put HIV, and we'll talk about our post-exposure prophylaxis is PEP, PEP, is what you'll sometimes see that listed as. Looking at my integrase inhibitors, we went over this, right, that I can use one of these with 2 of my NRTIs. I'm likely to not have a whole bunch of resistance, so this is good for us. When your patients start medication and then they stop it, and they start it again and stop it, this is increasing resistance, because I'm opening up my playbook, closing it, opening up my playbook, closing it. So we want them to stay on these meds, because we don't have a whole, it looks like a lot, right, because you're in PA school and you're studying right now. But some of these drugs, when people do disrupt their regimen, we see resistance start to develop to those drugs. And then that just makes it harder for us to treat our patient, and then they're more likely to have to start taking 3 separate pills instead of us having those 1 or 2 pills that they can sometimes take. Looking at their adverse reactions, just think about because it does have some CYP interactions, so you see that rhabdo, so think about muscle pain and think about CNS issues. So the suicide, insomnia, depression, so like muscles and CNS stuff. Okay, this is important for us as healthcare providers and looking at the potential of being stuck with needles. So y'all will go over how to like recap and things like that. Just please be very vigilant. Make sure that you are practicing those when you're dealing with needle sticks. We do see them still. So just please, you never know sometimes the status of our patients. Our patients may not even know their status, right? So just be very, 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 very careful. Again, these are our fluids that we were worried about, like those bodily fluids, anything that has blood, those tissues, things like that. We are worried that we can become ill or infected potentially. So what we do is we have what's called post-exposure prophylaxis, or PEP. And we are going to look at what we're trying to do, what meds we're trying to do. I don't need you to remember all of these words. I just need you to look at this, this bottom bullet for you to see the things that are not things that we're worried about unless you see blood, right? So if somebody was crying, sweat, they're like, you don't have to be like, oh, I can't touch them because they have HIV. Unless there's blood in these types of things, we are not as concerned. So just make sure that we're not treating our patients as if they're going to easily infect us, and that you're still like caring for your patient, talking to them, trying to get them on the right meds while you're also being very careful. We also see our PEP used in patients who have had any type of, if they were a victim of sexual assault. You can also see this used in those situations as well, okay? Because what if they don't know the status of that person who they were sexually assaulted by. So we can also put them on these medications to make sure that we prevent them from becoming infected. So again, our goal is 72 hours, but as soon as possible. As soon as that stick happens, you report it. We should be getting that patient on some med, or getting you on meds, your coworker, or that person who was a victim of sexual assault. Our prophylactic regimen that we have, again, we have 2 of our NRTIs, which was also a part of our backbone. So we have 2 NRTIs, and then I can do, again, my integrase inhibitor. I can do a protease inhibitor with that ritonavir, because remember my protease inhibitor, I usually have to boost it, which was my ritonavir. Or I can also do it in an RTI, okay? that is your option that you have, bless you. Most of the time, what you'll see is that we'll have them on these two medications for the 28 days. They will take the Truvada, which is your intracetabine, and your tenofovir, which is your two NRTIs, and then they'll do the dolutegravir, okay? Now, when they're doing that, they just need to make sure that they set an alarm, because now that one is going to be them doing it twice a day versus that Truvada, which is just once a day. And then when you're looking at your pregnant patient, you see that what's safe is going to be your raltegravir, so make sure that you're paying attention to that. I also want you to remember this duration, because this is something that will be very important to us as healthcare providers. So 28 days. Some patients may feel comfortable if they get that HIV status back and they're like, oh, it's negative. Some people may say, cool, I'll stop. Some other patients may be like, no, I'm good, I'm just gonna take my full 28 days, okay? So once you know the status of your source, that you can stop taking the PEP. You don't have to take it all the way through if you end up finding the source and you find out their status, okay? And then looking at your interactions, this is like if you're taking any type of supplements, right, that may have this. So you have some of our multivitamins that have a lot of these irons in there, and so that's why we're worried about trying to separate those out, because they can bind to our antivirals and decrease the absorption that we have, okay? This is just going through, again, all of the different options. What I want you to remember is the 28 days, and then you seeing these different options that we have here listed. It's the same thing that you saw on this slide, but just in a chart. I put the red box around this for you to focus on this if you do want to look at it. Again, you don't have to remember all of those names. You can just remember the class and pick out and say, okay, cool, I remember that these go to this class, and pick them out. Or you can try to remember each regimen. Up to you, okay? This is looking at PEP, P-E-P. Now, this is PrEP. So PrEP is, I am trying to say, before I get exposed, I want to take some medication. So you have several different indications. You have men who have sex with men. You have discordant relationships where there could be one of the partners has HIV, they're HIV positive, and the other one is not, and they still remain in their relationship, and they want to avoid the other person so they from getting HIV, so they can use PrEP. When we put patients on PrEP, we do continue to test them to make sure that they are still HIV negative, okay? So we still do testing even though we have them on this medication. So all I want you guys to remember from this is like IV drug users, high risk sex partners, people who are men with men, and your discordant relationships are mainly when we start to see PrEP being used. Now, we have several different regimens that we are allowed to use. A lot of our commercials, we have Truvada, Descovy, and then Apretude is the new one that you're seeing on the commercials. Your Truvada and your Descovy are going to be your oral formulations that you have, and then your Apretude is going to be an injection that they receive. Our ID department here was doing these. There are some programs, so when I was doing my residency, my co-resident, we made a program here at BNC where you can go to the pharmacy and get PrEP. You don't have to go to your provider. So if you guys are busy and you hear somebody saying like that they needed coverage and you don't have time because they want to start PrEP, you can send them to the pharmacy and the pharmacist will go through, we have like a stepwise approach, and then we can put them on PrEP until they can get to ID or until they can get to you all. We can fill them and they never have to even come to you if they don't want. And we work in conjunction with the ID department to do this program, okay? So it's also another option for your patients. So looking at here, just go down and look at when you can use these options that you have. So your Truvada, this is gonna be more so for your patients who are high risk due to sex, or they're IV drug users, or they're injecting themselves. More at risk, of course, if they're reusing needles. Then you have your Descovy that you have available. Remember, I'm also gonna give you the brand names of these. So just, if I were y'all, I would remember the brand name options that I have available, just saying. Your Descovy, this is again for your patients who are having sex. but not for your females at risk through receptive vaginal sex, okay? So this is for, if they were born a female, then this medication is not for them, okay? Is what this is saying. And then you have your Apretude, this is your IM injection that you have, and then you see the dosing schedule varies as they continue to take it. Make sure that they are, for all of these medications, testing to be HIV negative. The reason why that is because, is this our backbone? Does this have everything that we need for our backbone? No. So what we would be doing if somebody was HIV positive and they were taking this is we're just increasing resistance and decreasing our ability to get our patient on just 2 medications. Because now they'll be resistant to our big gun, which we like to use, which is Truvada, okay? So that's why we consistently test for HIV, any med that they're on for PrEP all the time. And then this is just looking at some of the considerations that you have, which is what we just talked about. Making sure that the patient is coming in, you can give them a 3-month supply at a time. When you initially start them, what I do see is that the provider will give them that 3 months with no refills to make them come back in. They do labs just to make sure that the patient is okay. Talk to them about adherence, make sure that they're taking the medication every day. Because if you're doing this for PrEP and you don't take that medication, is it prophylactically preventing anything? If the drug is not in their body and it's in the bottle? No. So that's why we also continue to test these patients, because if they didn't take their medication how they were supposed to, they can become infected, okay? That is the end of this lecture. So tomorrow, what we will do is we will have Dr. Sheps, who is our IV pharmacist, come over. And then what I'm gonna do today is I'm going to post, how many groups do you guys typically use for Clean Lab? Do y'all do groups? No? Okay. So what I'll do is I will, 1, 2, 3, 4, 5, 6, 7, 8. We'll break up into 8 groups. So typically y'all can just do your rows. And then, this will be for Wednesday, and then we will do our little in-class activity. So I'm gonna post what the sheet is, but you don't need to do anything before class. We're going to do all of this in class, and that will be our last lecture. And I'll try to bring us some little candies or something, so we can work nicely together. I'm around if y'all need me, let me know.